I'd like to welcome everyone to today's AHRQ web conference on improving health IT safety through the use of natural language processing to improve the accuracy of EHR documentation. Although a few people are still logging in, we're going to go ahead and get started on time. My name, as you heard earlier, is Chris Dimmick, and I will be moderating this webinar. I currently serve as the Director of the Health IT Division in AHRQ Center for Evidence and Practice Improvement. You should now be viewing the slide depicting the agenda for today's webinar. Please also note that we are recording this webinar, and the recording will be available via the AHRQ Health IT YouTube channel in about 2 weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning and were also available for download as you logged in today. We will also be sending the slides to participants via email following the webinar, along with instructions for obtaining continuing education credits. Before we get started, I wanted to take a moment to remind everyone about why AHRQ sponsors these webinars and how this work is related to AHRQ's mission. As a research agency within the Department of Health and Human Services, AHRQ's mission is to produce evidence to make healthcare safer, of higher quality, more accessible, equitable, and affordable, and to work within the department and with other partners to make sure that the evidence is understood and used. AHRQ works to accomplish this mission through a diverse body of work carried out by its research portfolios and offices. This work includes investing in research, generating materials, and providing training opportunities such as this webinar that can help to foster diffusion of research findings to the agency's key stakeholder groups and to the public. The Health IT portfolio at AHRQ has a long history of supporting research that seeks to answer some of the fundamental questions related to implementation of health IT. Among many current topics of interest in the field of health IT and AHRQ is ensuring the safe use of health IT. Today's presentations will focus on the development of innovative tools and methods to advance health IT safety through improved electronic health record documentation. AHRQ uses a number of funding opportunities to advance science in the realm of health IT, including the design, implementation, usability, and safe use of health IT. Current opportunities are listed on this slide for those who may be interested. We're pleased to have two esteemed researchers with us today. They are Dr. Thomas Payne, Professor of Medicine and Adjunct Professor in the Departments of Health Services and Biomedical Informatics and Medical Education, and Medical Director of Information Technology Services at the University of Washington, and Dr. Li Zhou, Assistant Professor of Medicine at Harvard Medical School and the Brigham and Women's Hospital. This webinar event is accredited by the Professional Education Services Group. And for those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that neither AHRQ, AFYA, RTI, PESG, our presenters, nor myself have any financial interest to disclose. Lastly, please note that no commercial support was received for the development of this learning activity. Just a quick note regarding our presenters' current research. The work that's being presented here today was funded by the AHRQ Health IT grants listed on this slide. In addition to serving as a co-investigator on numerous grants and contracts not listed here, Dr. Payne is also currently serving as the PI on a grant from the Association of University Radiologists. Likewise, Dr. Zhou has served as principal investigator on multiple research projects funded by AHRQ, the Controlled Risk Insurance Company, Partner Siemens Research Council, and Harvard China Fund. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, please feel free to submit questions for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in listen mode only, so to ask questions, you will need to use the Q&A panel. This slide shows the learning objectives for today's webinar. By the end of this webinar, participants should be able to discuss the development and evaluation of an enhanced electronic note system that leverages voice recognition and natural language processing technologies to create electronic physician notes in the EHR. Secondly, discuss the challenges of introducing speech recognition technology into existing medical culture and current clinician workflow, including using preferences and the quality of documents generated by this technology. And lastly, explain the need for an automated error detection system using natural language processing for improving the accuracy and quality of speech recognition-generated medical documents, and discuss the development and evaluation of such a system. And now, it's my pleasure to introduce our first presenter, Dr. Thomas Payne. As noted earlier, Dr. Payne is Medical Director of the University of Washington's Medicine IT Services since 2000 and Professor of Medicine and Adjunct Professor in Health Services and Biomedical Informatics and Medical Education at the University of Washington. He is an attending physician in medicine at the University of Washington Medical Center and Harborview Medical Center. He also serves as board chair of the American Medical Informatics Association. His research interests include natural language processing and electronic documentation in EHRs. And now I'll turn the control over to Dr. Payne.
Thank you, Chris, and hello to all of you. I am looking forward to describing our work on the topic you see displayed here, which is to improve the accuracy of electronic notes and also to make generating them faster and simpler. The objectives of this presentation are to review the problems with the current note writing practices that physicians use in the inpatient setting, to see how each of these problems could be addressed using current technologies and also using commercial EHRs, which are the kind used by most practitioners in the United States. And thirdly, to understand barriers to changing physician documentation practices and how to address them. Some of these topics are familiar, very familiar to those listening, and others might be new. So I'll describe them assuming that much of this is new to you. I want to add this disclaimer that we've recently concluded the collection of data and we are analyzing it. We have not yet performed statistical testing that we have in mind to do. And so the results that you may see in published literature might be slightly different from those you see presented here. Before I begin, I want to define some terms that I will be using and that Lee will be using following my presentation so that it's as clear as we can be about what we mean by these terms. First of all, automatic speech recognition, we define as using software to convert a spoken speech into text. There are many commercial products that do this. You might be familiar with some of them. One example would be Dragon Naturally Speaking, but there are many others. Secondly, there are ways to use this automatic speech recognition software that differ in how the user is involved in generating the text. The first is interactively. And in this method, the user speaks into a microphone and watches the screen as the voice is converted to text, and then the user corrects any errors that may occur interactively. So this is an interactive method. The second way to use automatic speech recognition software is non-interactive. And by that we mean that the user creates a voice file containing the entire document by speaking into a telephone or voice recorder. Then automatic speech recognition software converts that voice file into text in the background while the user is engaged in other activities. Finally, either a transcriptionist or the user corrects any errors that might be present in the document that's created. So the automatic speech recognition software is usually the same, but the ways it is used differ between interactive use and non-interactive use. So as you heard in my introduction, I spend time in our hospitals, and I will be next week beginning in one of our hospitals. And this is a picture that I took with all the patient information de-identified of my team on a typical late morning. And what you see here is these very, very bright young physicians looking at their computer screens. So although I'm involved and have been involved for 16 years in moving from paper to electronic systems, I am fully aware that there are problems as a result of this transition, and I view this as one of those problems. These clinicians spend more time than they should working on a computer and less time at the bedside or speaking with families or in conferences. And that's really what led to my becoming interested in this work and applying to AHRQ to fund this research. Problems other than what you saw in that picture include that notes that we write using electronic systems are often bloated or far longer than they really need to be. Copy and paste is common, and usually this is because physicians are trying to save time, and they do this to reduce the time it takes to create a new note. The third of several longer list of problems is that as a consequence of the time it takes to create a note, they finish their notes late in the day, and that limits the amount of time that other team members have to view those numbers. And in some cases, team members such as the bedside nurse may not see the progress note until the next day. That isn't the idea of communication with progress notes. The idea is that we communicate in a more timely fashion. So here's an example of that last point. Here is an electronic note, portion of it anyway, and you can see quite thorough listing of the patient's problems. But if you were to examine the audit log for this note, you could see that the note was signed and available for others to see late in the day, often 5, 6, or 7 p.m. This is a problem because the people who would benefit from seeing this don't see it until much later. So that's what led to our proposal, which we were very pleased was accepted and funded by AHRQ. It had two specific aims. The first one was to refine and implement a new voice-generated enhanced electronic note system, which we abbreviated VGEENS, which integrates voice recognition and transcription with natural language processing and links the note process to the electronic medical record so that we could improve the efficiency of note creation and improve the accuracy of those notes. So the first specific aim was to create and implement this system. The second aim was to evaluate it using a randomized trial in which we used roughly 30 internal medicine physicians who were randomized to use note writing tools as they always have, at least over the last decade, and the intervention group, which would use VGEENS, this new system, to create notes. And then we compare a variety of outcomes between the intervention and the control group. So this, by the way, is a rather ambitious set of aims for a grant that it runs over 2 years, but we'll tell you how it went. Regarding specific aim 1, this is an illustration of hospital ward just to show you how we envision the workflow changing using this VGEENS systems. The idea is that notes are dictated at the bedside or immediately after leaving it, so that as the team sees a patient in one room, they create the text for the progress note, at least in draft form, before they move to the next patient, and the third and the fourth, and so on. That was what we had in mind for the workflow in using this system, which is quite different than the usual way notes are created, in that often scribbled notes are entered on a piece of paper, and the note itself would be written in the physician room, which was the picture that I showed you earlier in this presentation. So this is the workflow that we were targeting. Now, the technologies that we considered using to achieve this objective are listed here. We could type notes using a keyboard, which has several advantages. However, it is less well adapted to rounding workflow. Traditional dictation is fast to generate and is well suited to rounding workflow, but the turnaround time for dictation sometimes is a barrier because those notes are intended to be viewed by others the same day, and there are other limitations. The last on this is voice recognition, which is low cost, but I mentioned that in the interactive form of using voice recognition software, it isn't particularly well suited to rounding workflow. Hence, we developed VGEENS, which was intended to be fast, low cost, to incorporate EMR data, to include encoded data, and to be well suited to rounding workflow. So that was the vision for this project. Specific aim 2 was the evaluation. And here is a quick illustration of how we organized this trial. We had consented inpatient physicians who were on the medicine service in our 2 main teaching hospitals. They agreed to participate and then were randomized to one of 2 arms. On the left, half of them were to use the VGEENS tool to document their inpatient progress notes, and half of them were to use the usual methods to write their progress notes using a keyboard with the tools provided by the commercial EHR. So that is the intervention and how subjects are randomly assigned to the 2 arms. We expected that they would create between 5 and 15 notes per day for as long as they were on an inpatient service, and then we would measure several outcomes to determine the impact of this intervention. The first is the number of minutes that elapse between the time a patient is seen on rounds and the time a note is signed and available for others to see in the EMR. The second was note quality. Note quality is more difficult to measure, but we used the physician's document quality instrument that has been described in the literature as a method of estimating note quality. We also added an additional question as an indicator of quality. And the third outcome is the satisfaction of physician users. The reason that we chose 3 outcomes was that we could envision that it may be possible to write notes faster, but their quality would be lower, and that wasn't our objective. Our objective was notes that are written faster so that they're available for others to see while maintaining quality and maintaining the satisfaction of the physician users. So that's a brief description of specific aim 2. This is a reprint of the physician's data quality instrument, which is hard to see on the screen, but if you were to look this up in Medline, you could quickly find the literature on this, and you can see that it includes attributes to notes that most people would agree are important when assessing note quality. The other thing to know about this instrument is that it is a fairly time-consuming instrument to use if you are going to assess each of these attributes in each note. And this is done manually. All right, so now on to results. Well, the first result is that we actually were able to create and implement this VGEENS system, which was reassuring. It's you never know when you start out on an initiative whether you might run into barriers that you didn't foresee. We were successful in creating the system, having it reviewed by our security team, and introducing it into production for use in this trial. It is used with a commercial EHR. It doesn't require that you use one EHR or another because it leverages the ports that most EHRs have for incorporating dictated notes. In this case, the notes were created using VGEENS, but it's the same port that EHRs permit you to include dictated notes. The notes that are created using VGEENS are available within the EHR inbox within 5 minutes. So that a criterion was achieved. It is secure in that the transmission of the voice file is through an encrypted channel, and the file is deleted as soon as it has been successfully received. Yet the file is enhanced using text processing. Some of these enhancements were available later in the trial and not at the outset, but this was important because having a voice file as it comes straight out of the automatic speech processing system is really not acceptable to most physicians. It needs to be formatted in a way that people are used to when seeing a progress note. And we can also incorporate laboratory results, vital signs, and other data in response to voice commands during the dictation. It was quite reliable. There was some downtime, but it was uncommon, and most of it occurred early in the course of our trial. This is another diagram to show how this worked. The voice files were created during rounds. They're transmitted to a server where the processing took place. And you can see that on this diagram, it went to the server. Automatic speech recognition was applied to the voice file. There was, in some cases, extraction of concepts using natural language processing tools. It was formatted, and then it was inserted into the inbox of the commercial EHR. And this occurred within 5 minutes of the creation of the voice file. So here are the results at high level. You can see that we had 24 intervention subjects and 25 control. Because of the vagaries of scheduling on our hospital wards, we had fewer than that who actually contributed notes to this trial, but sufficient for our purposes. Interestingly, the participants were very, very helpful to us in recording the time they saw patients. They wrote down the number of they wrote down the time when they saw the patient on rounds, which is key to outcome 1 in every case. They wrote a large number of notes, and 100% of these subjects completed a satisfaction survey at the end of the trial, a response rate that I've not seen before. The outcomes were something I'll go through in more detail shortly, but you can see that in aggregate, there was a slightly higher number of minutes between rounding and the note being available in their intervention than control. Satisfaction was about the same. Because of the change in workflow, some physicians were less satisfied with the intervention than with the control. And note quality assessment is underway, since that is more labor intensive. So here are the first of the histograms slides that I'll show you. And this one shows the number of notes on the y-axis, and the x-axis shows the number of minutes from midnight when the patient was actually seen on rounds. So not surprisingly, you can see that most of the patients were seen in the morning. 480 minutes from midnight is roughly 8 a.m. So you can see that the R under residence corresponds to 8 a.m. Most of our patients were seen on morning rounds. Not always. Some patients were admitted later in the day and were seen at that time. So this just shows that our data is capturing the time that patients were seen. The next slide is an interesting one, and it shows in the intervention group the number of minutes from midnight when VGEENS was used. And you can see that there's a peak, a trough, and another peak. And this shows that there were some physicians who used VGEENS immediately after seeing the patient, which was our workflow expectation. However, we did not train them or ask them to use it at a particular time. We left that up to them. So some physicians used it as we envisioned at the bedside or soon after seeing the patient. Other physicians used VGEENS later in the day, which was up to them in this exploratory trial. As a result, the number of minutes from midnight when the VGEENS notes were available was also different. It depended on when the note was written. And you can see sort of a bimodal distribution here. Those who created their notes early during rounds or at the bedside had notes available much sooner, and those who used VGEENS later in the day had their notes available later. And that explains the difference in the time data that I showed you in the summary results several slides earlier. I think the interesting point here is that as the next step, we intend to encourage physicians and actually monitor them to see that they use VGEENS earlier in the morning rather than later so that others can see their notes sooner. This colorful slide shows the same data that you saw previously, but each color represents a single physician. So you can see that there are some physicians, for example, the physician who is represented in the brown toward the bottom, used VGEENS early, and another very prolific physician who has sort of a purple color on the right used VGEENS later in the day. And this was his or her choice. However, we had in mind that it would be used earlier in the day rather than later, and we did not give them feedback on this during the trial. So the time until notes were viewable using attention to treat, which includes those notes that were created in the rare circumstances that VGEENS was down, we asked them to write the note as they usually would, so those data are lumped together with the notes created using VGEENS. And what you can see here is that intervention and control, the distribution is very similar, that there wasn't a dramatic difference between the time that notes were seen after the patient was seen on rounds in the morning between control and intervention. And it's for the reasons that I mentioned earlier. This is a slide that shows for control subjects whether there was a difference between attending and resident physicians. And the answer is that there is not an important difference. The practices of attendings and residents were very similar. Now, this slide is hard to see, but the point I want to make is that there are differences in color between the VGEENS note that you see on the left, and this is de-identified, and the note written for using control methods on the right. In this slide, blue represents text that is changed, added, or removed. Black represents text that is the same when compared with the note for the same patient the previous day. So this illustrates an important point. When you create a note using VGEENS, you are free, of course, to look at the previous day's note, but it's easier to do it with what you have in mind from seeing the patient on rounds. So you begin basically every note from the beginning and record what you heard on history, what you found on physical exam, and what your thoughts are about the plan for the next day. And so you can see that there is more blue text on the left for VGEENS than there is on the right in control. And in fact, if you were able to look carefully at the physical exam in the control note on the right, you would see that almost none of the text has been changed. It may be that this is because the exam was performed both days and it was identical, or it may be that the previous day's physical exam was copied into the current day's note and not changed, even though there might have been subtle differences. So this is an interesting hypothesis, but we did not pursue this. It makes me wonder, though, whether we may end up with differences in accuracy of notes using VGEENS versus control. So now on the point of introducing any intervention into the busy workflow setting, I'd like to quote, it's attributed to Homer Warner, what is medical informatics? Well, it's 10% technology, it's 10% medicine, and it's 80% sociology. I think Dr. Warner was right about this. Introducing something that's new takes effort. We learned that house staff, and particularly interns, are unfamiliar with dictation and were a little bit reluctant to use it. More experienced attendings were willing to use it because they had more familiarity with it. They also wanted, the interns and residents felt uncomfortable when their notes looked different than those of their colleagues using VGEENS, and this was something they considered to be a concern to them. So for any intervention, particularly things that have to do with notes, the sociology, the human reaction to change is important to consider. Lessons learned. We learned that physicians may resist changing their established note writing habits. The VGEENS approach can create a progress note faster if the voice is recorded at the bedside or soon after. And that was the case for many of our subjects, but not for all. We learned also that notes created using voice may contain less text carried forward from prior notes and may be more accurate, but we did not measure that in this R21. Features popular with physicians were, in both cases, they like to carry forward their plan. They like to include checklist information such as code status, phone numbers for next of kin, and they also like to minimize editing requirements. The successes of this trial are that we created this system that worked in production, created inpatient progress notes within 5 minutes using a commercial EHR. We learned that if you use it at the bedside or soon thereafter, when your memory of the findings is the greatest, the notes will be available much sooner for others to view. And they may those notes may contain less text carried forward from prior notes. This gives us the potential to apply decision support based on progress note content within minutes of seeing a patient on rounds, which is an exciting opportunity to provide useful decision support that can be acted on during the workflow of hospital care. The challenges we ran into included that changing note writing habits runs into resistance from people who are familiar using one method. We discovered that on average, satisfaction was greater using the control method of note writing, and that was probably in part because these enhancement features, such as formatting and inserting vital signs in lab, were not available until later in the trial. From a first-time principal investigator, if there are some of you out there, developing a system to be used in production and conducting a randomized controlled trial in 2 years is an ambitious goal, but you actually can achieve it. People are enthusiastic about joining a project. We were very pleased and gratified that our colleagues signed up to participate and at both the subjects, but also in our team, which you'll see in the final slide. It generated a lot of buzz, a lot of enthusiasm. I would say be sure you pick a problem that you know is important, that you have a deep understanding of, because it will help you create the trial in a way that's helpful. Also, begin thinking about your next project on day one of that project. So we have lots of ideas that we want to add and build on what we've learned in this trial. This is our team, and it supports my statement that diversity helps. We have people who are house staff on the right and graduate students. We have electrical engineers. We have our information technology services team and my colleagues in the Department of Medicine and Department of Biomedical Informatics. I want to express my gratitude for AHRQ for making this possible. I'm incredibly grateful to their support in taking a chance with a trial this ambitious, and I'm pretty sure it's going to pay off. We have lots of ideas to build on this work. So thank you very much, and now I'm going to pass the baton to my colleague, Lee Jo, and let her take it from here.
Yeah, thank you very much, Tom. We really enjoyed your presentation. As a reminder to everyone, we'll be taking questions after both presentations. So please submit any questions you have for Dr. Payne using the Q&A panel. I saw quite a few come through already. So I'd like to introduce Dr. Zhou now. She's an assistant professor in medicine at Harvard Medical School and Brigham and Women's Hospital Division of General Internal Medicine and Primary Care. She's also a senior medical informatician in clinical informatics with Partners eCare at Partners Healthcare Systems. Dr. Zhou's primary research areas include natural language processing, temporal reasoning, knowledge representation, terminology standards, and clinical decision support. So, Dr. Zhou, we're looking forward to your presentation. Thank you.
Thank you, Chris. Good afternoon, everyone. Today I will talk about the quality and accuracy of clinical documents generated by speech recognition technology. I will present an error analysis of those documents and discuss a plan for using natural language processing to improve the accuracy of the documents. It is well known that accurate medical documents are critical for high quality and safe patient care, and it's also important for effective communication and care coordination between providers. Errors in medical documents can lead to medical errors in patient care, and some of those errors can cause injury or even death. So, for example, about 5 million errors per year are tied to wrong medications, and 1 in 4 medication errors involves a pair of drugs whose names look alike or sound alike. So, although they look very similar, Altanol is a brand name of acetaminophen used to relieve pain or reduce fever, while atenolol is a beta blocker that treats heart disease and hypertension. And this picture on this slide tells us a very sad story. The 62-year-old grandma in this picture was supposed to take a pain drug called Lyrica, but instead she received another drug called Lamictal at high dose, which has no side effects or suicidal thoughts. 2 days after starting Lamictal, she committed suicide. This drug mistake might have been caused by a garbled telephone message or spelling error. Spelling errors can happen due to either non-word errors, which often occur in free text entries or typed notes, or real word errors, that is, a word spelled correctly but contextually wrong, such as there for there. Speech recognition software generated text often contains real word errors. First, let's look at non-word errors. Kenneth Lai in our research team examined spelling errors in 300 medical notes, more than 2,000 of free text allergy entries, and free text medication orders. We found the error rate in clinical notes was about 0.5%. That is, 1 in 200 words were errors. Error rates in free text allergy entries and medication orders are much higher. 4.5% and 7.5% of words were misspellings, respectively. Among all those errors, 28 of the errors are clinical terms in notes. 2/3 are clinical terms in free text allergy entries, and 78% in free text medication orders. Most of those errors were non-word errors. Only about 4.8% of all errors in notes were real word errors. Based on this error analysis, we developed a spell checker in our amateur natural language processing system. For error detection, we used a comprehensive dictionary compared from many sources, including a couple of standard medical terminologies such as UMLAS, SNOMED, XNOM, etc. Our error correction algorithm is based on noisy channel model, and we also used added distance between the misspellings and suggestions. To evaluate and compare our system's performance, we use ASPEL default setting as baseline. ASPEL is an open free software spell checker. We saw a significant improvement in our spell checking regarding to precision of method and accuracy. So now let's look at speech recognition and real-world errors. Although speech recognition technology has been widely used in medical practice, the quality and accuracy of SR-generated clinical documents hasn't been thoroughly studied or reported. According to a most recent review of SR technology in healthcare, only a few U.S. studies report error or accuracy of SR software. Our limiting scope and sample size, for example, one study used a discharge summary and a progress note, and another one involved two physicians dictating 47 emergency department charts. The reported SR error rates varied from 1.5% to 15.2 by word. And much higher error rates have been observed in more recent and larger studies in radiology. For example, Baseman reviewed 615 imaging reports at 2 hospitals in Canada, where half of the sample were generated with SR software and another half used conventional dictation transcription. At least one major error was found in 23 of the SR reports as opposed to 4% in conventional dictation transcriptions. Interestingly, however, 76 of the radiologists believe that their own individual error rate is less than 10%. Our co-investigator, Foscos, conducted an error analysis using ED notes. We retrospectively analyzed 100 attending emergency physician notes that physicians dictate directly to the EHR using speech recognition software. The physician further edited and signed the notes. We found that 71% of the notes contained errors, 1.3 errors per note, and 9 errors per 1,000 word. And 15 of the notes contained one or more clinically significant errors that may potentially affect patient care. Such errors could be relevant medical history, medication dosage, etc. We also found that proofreading the entire medical notes to search for errors is time-consuming, as evidenced by physicians signing their notes with no errors. We also recently conducted a clinical survey in our institution, including 114 clinicians who use Dragon software to dictate notes directly to the EHR, and 50 clinicians who use phone to dictate their notes, and the notes are sent to the transcript service to be transcribed. In general, most of the participants responded that the average number of errors per note is about 1 to 5. However, compared to the transcription service users, Dragon users reported more errors per note. So in the following slides, I will present our ongoing study funded by AHRQ. This study has two major aims. First, we conduct error analysis to estimate the prevalence and the severity of speech recognition errors. And then we will develop natural language processing methods for automated error detection. In this figure, you will see different document processing stages when involving speech recognition technology. Tom has introduced the two modes of speech recognition, non-interactive versus interactive. Although we also call it back-end or front-end, the idea is similar. In the back-end or non-interactive SR, a clinician dictates using a phone. His or her voice is sent to the transcription services, who use speech recognition engine to transcribe voice to text. The text is then reviewed and edited by a medical transcriptionist. The corrected document is then sent back to the physician for review and signature within the electronic health records. While in the front end or the interactive mode, a clinician dictates directly into free text fields of the EHR and make edits before saving the documents. So this presentation, we report our error analysis in back-end or non-interactive SR-generated documents at different processing stages. Our study tries to include different types of clinical documents because each institution may use transcription service only for certain document types. For example, at Brigham and Women's Hospital, we does not use back-end transcription service for discharge summaries. We therefore include the major document types available in those three institutions. We select a stratified random sample of notes based on the proportion of each document type stored in our data repository. By now, we analyzed 169 dictated notes, which include 24 operating notes and 55 office notes from Brigham and Women's Hospital, 40 discharge summaries from North Shore Medical Center, which is a community hospital in Boston, and 35 discharge summaries and 15 operation notes from University of Colorado Hospital. We analyzed the notes at 4 processing stages, including original audio file dictated by the provider, we call it AO note, notes generated by speech recognition engine of the vendor transcription service, we call it SR note, notes edited by a professional medical transcriptionist, we call it MT note, and the final notes reviewed and signed by a clinician, we call SN note. We developed 3 levels of annotation schema. The general error type including insertion, deletion, substitution, etc. Semantic error types including general English errors versus clinical information errors. We also assess whether those errors are clinically significant, meaning that they may potentially impact patient care. To create good standard notes, we used the transcription notes and the final notes, and also listened to the original audio files. We measured the length of the time to dictate the notes and the turnaround time for each notes version. We compared difference in notes at different processing stages from the gold standard. We calculate the error rate, which is number of errors divided by the number of the words. We calculate the percentage of each error type by all errors. We also calculate the percentage of notes with at least 1 clinical significant error. We repeated this analysis for each processing type, stage of the notes for each note type and across all notes. To dive into the general error types, we classified errors into a set of general errors types as shown in this table, including insertion, deletion, substitution, number, and punctuation errors. For example, insertion means that 1 or more words was added to the transcription. And one example shown in this table is the speech recognition engine added no in the text and changed the meaning of the sentence. If you look at the one of the substitution errors called a homonym error in the middle of the table, it means that 1 word has been substituted for another identically pronounced word. Example about serial high resolution endoscopy was shown in this table. We also classified the error into different semantic types, including general English, stop word, deletion, substitution, number, and punctuation errors. For example, insertion means that 1 or more words was added to the transcription. different types of clinical information, such as medications, diagnosis, lab, imaging tests, procedure, physical exam, etc. If you look at the bottom of this table, when the SR engine couldn't recognize the word and the transcriptionist was not sure what had been said in the audio, they put a question mark in the text to let physicians to fill in later. So we also count those marks. So now I will go through our preliminary result. The average length of the notes was 558 words, ranging from 100 to 1200. The average dictation time was 5 minutes, ranging from 20 seconds to half an hour. The turnaround time is the time between physician completion of dictation and the transcriptionist edits sending back to the electronic health record. The average of the turnaround time is about 3.5 hours, ranging from 2 minutes to 39 hours. Clinician review time is the time between the notes upload to EHR and the clinician signing of the notes. The average time was 4.2 days. The longest one is 42 days. This slide shows the overall error rate and the general error types. The overall error rates varied among different note types. Across all errors, highlighted in red, the overall rate for speech recognition generated notes is about 7.5%. After the transcriptions review, the error rate was dropped to 0.6%. After the physician reviewed and signed the notes, the error rate was 3 in 1,000 words. The most common error type in discharge summaries and office notes was deletion errors, followed by insertion and enunciation. The most common error type in operative notes was insertion. And this graph may demonstrate a better view. You can see for SR notes, discharge summary had the highest error rate, followed by office notes and operative notes. The error rate dropped significantly after transcriptionists edited the notes. This slide shows errors by semantic types. You can see most of the errors were English, and error types varied among different types of notes. Across all notes, the most common clinical error were medications. About 2.6 of the errors in SR notes were medication errors, 3.7 in MT notes, and 2.1% in side notes. Other common clinical errors were related to diagnosis, procedures, and symptoms. This figure shows the clinical information errors in speech recognition generated notes by note type. So you see in discharge summaries, the most common errors were related to medications, followed by diagnosis, symptoms, lab, and procedure. In operative notes, the most common errors were procedures, followed by diagnosis, which makes sense. In office notes, the most common errors were diagnosis, followed by medication. And this table shows the error rate change in regarding to English errors versus clinical information errors across the 3 stages of procession. You can see in the speech recognition generated notes, the clinical error was about 10%. The transcriptionist tended to fix most of the general English errors, which led to a high proportion of clinical errors in the MT notes, 20%, compared to the SR note. At the end, there were still 61 out of the total of 691 of clinical errors it's about 9% that errors generated by speech recognition left in the sign notes and corrected. We also found that 40% of SR notes, 7% of MT notes, and 5% of SR notes contain at least one clinical significant error. So we also found that the transcriptionists and clinicians often rearrange or made stylistic changes to the text. In 17% of the notes, transcriptionists rearranged text. For example, copying or pasting entire paragraph sections and move them higher or lower in the document. The transcription usually does this at the request of the clinician. The document say, please put the previous 3 sentences and the history of present illness. And we also found that the transcriptionists often made a stylistic changes to the text. They do minor grammatical fix, rewording sentence to make more clear without changing meaning. When the clinicians review their notes, they often added or deleted information before signing the notes. So here shows you some error examples, such as TB vaccine versus TD vaccine. The second example is a patient continues to have daily staining, was transcribed as staining. The ISR software transcriptionist and the sign notes all missed this error. Menoringer and gloating allergy were missed by ISR and transcriptionist and remain omitted on the sign notes. In the last example, the ISR software and transcriptionist missed the name of the drug and listed using question mark for clinician to fill in. The drug said in the audio was celecoxib. The SR and the transcriptionist notes didn't record it, and the clinician signed notes and listed the drug as another drug, naproxen. To discuss our finding, our results showed that back-end dictation service has a relatively quick turnaround time and a low error rate. Well, many errors were generated by speech recognition. Most, around 94%, were corrected by the medical transcriptionist. And this suggests that the addition of a human editing of speech recognition generated notes is very important. A recent study of EHR-related malpractice cases found that 20% of the malpractice cases were due to inaccurate information in their EHR. Although the percentage due to the dictation is unknown, this demonstrates that without transcriptionists and clinicians revising the notes, clinical significant errors could have had a negative impact on patient care and potentially cause legal issues. We found that errors still left in the signed notes, suggesting that some providers may not review their dictate notes thoroughly or at all. For example, we also found that 7% of signed notes contain a black space. The transcriptionist marked as with question mark, indicating they were unsure of the word and for the physicians to fill it in. Those cases indicate if physicians use speech recognition tool directly, they may have to spend a considerable amount of time correcting the ISR-generated text. Although the errors could be less than our results, because the SR can be trained by the individual in clinicians. Therefore, automated error detection is needed because it may save transcriptionists and physicians' time for revising their notes and help improve the accuracy of dictated document. So as I mentioned, our studies are going. Here are some of our other ongoing efforts and the next steps. Currently, we are also conducting error analysis for front-end use of SR by observing physicians dictating in clinical settings. We also recruit clinicians to do simulated dictation experiments. We create patient case scenarios for clinicians to dictate. Based on our error analysis, we will build a collection of confusions that include the words intended versus the word mistakenly recognized. We also have the annotated error corpus, have the error frequencies and error patterns. Based on those efforts, we will then develop automatic methods to detect speech recognition errors. We will try and combine statistical methods such as noisy channel models, co-occurrence statistics, use the machine learning methods, and knowledge-based methods. Here, I would like to thank AHRQ for funding this study. And I also want to thank for all our research team members. I would like to thank our hospital and informatics team for their support and help. Thank you, everyone. Now I'm drop the ball to Chris.
Thank you, Dr. Zhou, and thank you again to both of our presenters for their very terrific and informative presentations. This concludes the content portion of the webinar. Now we have a few minutes left for questions. You can type, just a reminder, you can type them into the Q&A section of the WebEx portal. We may not be able to get to them all, but we'll answer them all in writing and send the questions out to all attendees. So we had several come in during Dr. Payne's presentation. Tom, we'll start with one that asks if any nurse practitioners or physician's assistants participated in your work.
So good question, and that's the intention over time. We limited it to internal medicine physicians writing progress notes because of the size of the study and the need to complete it all within 2 years. So the answer is no, but that is a logical extension of this work.
Thank you. And I'm not sure if you can answer this or not, but we had a question about whether you anticipated selling your software via Cerner's Smart on Fire.
We aren't in the software marketing or development business, but I know that the commercial world is already looking into approaches similar to this. The advantage of using this approach, which leverages commercial products, for example, our speech recognition engine was a commercial product, Nuance, Dragon, Naturally Speaking, the medical practice version, and we used the Cerner EHR. The advantage is that we can leverage what the commercial world has produced, but we put it together in a different way, and it gave us the flexibility to add features that our physicians wanted, such as a lot of attention to formatting and the ability to extract data. Using FHIR, the FHIR developing standard through HL7, is a really intriguing way to extend this, and we're excited to try that.
Great. And another question about just the platform. Was it deployed on a Citrix platform?
Yes, although when they use it at the bedside, all they're using is it's basically a smartphone with the cell phone features disabled. So that's all they used at the bedside. But when they edited it and signed it, yes, it's on an EHR delivered through Citrix.
Okay, thank you. And you mentioned the bimodal distribution that you saw. There's a speculative question here about whether that could be due to new patients being admitted later in the day. giving you the later in the day usage?
Well, that bimodal distribution was the time between the patient is seen on rounds, whether that's morning or afternoon, and the time then the note is available for others to see. So that particular slide would not be different whether the patient was seen in the morning or the afternoon.
Okay. There's a question that also came in about whether during the course of your project you saw a dip in quality improvement in meaningful use measures. Did everything make it to the right box to be gathered into the reports that were needed for those quality improvement and meaningful use reports?
Yeah, I'm also very well connected here to those efforts, and this didn't affect our quality improvement or our compliance efforts. In fact, we're still examining the effect on billing. It's an interesting hypothesis that it might have an effect on billing, and we don't know whether it does or not. I suspect that it would enhance billing. It's a more accurate, complete note. And secondly, compliance with meaningful use criteria, we have software that automatically extracts problem concepts for clinicians to choose from. So if anything, I would expect the effect to be neutral on compliance with meaningful use.
There was also a question that came in about, how the physicians and patients felt when it was the case that there was actually transcription occurring or the information was being recorded in the room.
Well, that's the practice for many physicians already. Many of my colleagues, even when I was a student, had the practice of creating their note in the room with the patient. And I do this some myself. The advantage is that who is the world's expert on how the patient is feeling? It's the patient. So if I say something that is not correct, the patient is there to correct it. I didn't gather data on reaction of patients in this study, but my sense is that we're moving toward greater involvement of patients in participating in their notes.
Thank you. Lee, we have a couple of questions here for you. The first one is there data to show that completely new note text is more accurate and complete than reused text that had been reviewed for accuracy, which is what physicians should be doing?
That's a good question. That's a really good question that we haven't do the analysis looking at their documents that was not dictated by the speech recognition or transcription services. So that's a future a study we will look into. Yeah, because the using a template or using a character or typed notes, they can more, use the copy paste functions and may including the old information that should be updated.
Mm-hmm. Thank you. And this is a question that I think both of you might want to tackle. There are commercial speech recognition products like M-Modal, which provide immediate decision support regarding completeness of documentation and allow nurses to scan large volumes of notes to search for specific terms like sepsis. Do either of you have any thoughts or want to comment on those types of products?
Well, I could mention that I'm well aware of that market. I think it's exciting. It is focused on one particular area of decision support. I think that it demonstrates the potential to improve what's written and what's done for patients by analyzing the content of the note in near real time. So yes, M-Modal does this. Others do as well. I'm interested in helping with differential diagnosis or management decisions, and CDS delivered at the point of care based on NLP analysis of a note gives us new opportunities.
I also heard that there's ongoing effort to looking at the medications and the problems mentioned in the notes. that were not on the structured list, like problem list or medication list, that speech recognition can pick up those diagnoses and medications for medication recapitulation or make the problem list more accurate and complete.
Thank you. This is also a question that either of you might want to tackle. So for medical documentation NLP research, do you have any recommendations for note annotation tools that flag differences or topics, for instance?
Do I have recommendations? I think most physicians would be grateful for assistance with making sure their note is accurate and complete, and annotation for that purpose I think would be well regarded. It would have to be highly accurate, because physicians have low tolerance for annotation or decision support that they see as not adding value or potentially steering them in the wrong way. So I don't have personal experience with those tools. Maybe Lee does.
This is a very challenging research problem, and we think for simpler solutions, like we saw a lot of question marks that transcriptionists couldn't recognize what's going on. They use the question marks to flag it for the physicians to let them fill in. So for those type of the things, then we could do automatically annotate the notes and ask physicians to fill the information in. And also, we found by doing error analysis, we found that most of the errors are actually general English errors or stop words errors. These may not clinical significant. We should put more efforts on those errors that related to clinical information, for example, sounds like or look like medication errors or diagnosis errors. If we can flag those terms that which can potentially make the difference, that will be very important and valuable.
Thank you. Tom, this one's for you that came in. Any comparison of length or complexity of notes with regard to VGEENS versus the control?
Oh, interesting question. And that we're doing that analysis, but I don't have results. I've looked at enough notes to know that VGEENS notes are shorter, and most of my colleagues regard that to be a good thing. For example, some notes contain the entirety of a radiology report or a complete laboratory listing for that day, whether or not it's relevant to their observations. And I can tell you, as a physician who looks at a lot of notes, I find it harder to have a very long note and to understand what really happened and what the physician's thinking is. If you have a shorter note that's more to the point, that allows me to understand what the problem is with that patient and what we're doing about it more succinctly. So I suspect VGEENS notes will be shown to be shorter.
Okay, interesting. We'll be interested in your results. So here's a question that you both might want to tackle. Will speech recognition data entry ever reach a tipping point in which it becomes the predominant data entry process used by clinicians? If so, when do you predict this will happen?
Well, I work in IT services, and down the hall, I took a picture of a large pile of boxes of microphones being used for voice recognition in our clinics. And that stack was going for recycling, as you might expect in Seattle. It is taking off. Voice recognition in our world is climbing dramatically. So I think, at least in the outpatient world, we may have reached that tipping point. On the inpatient world, the interactive voice recognition isn't as good a fit for rounding workflow, and so I don't think we've reached that point yet.
Lee, did you want to add anything?
in the past decades, like the users of speech recognition are mostly radiologists or ED physicians, and now inpatient, and also like at Brigham, we also have their hospital-wide efforts of using speech recognition technology for all types of the clinicians to adopting this technology. I think it's amazing. I think once the technology get more mature and people know how to use it, it will make a big change.
Thank you. Lee, I think this next question that came in is for you. When counting errors as insertion or deletion errors, was that compared to the original voice file and confirmed that the words that were added or deleted were originally spoken?
Yes, because we listened to the so for the speech recognition software generated notes, we compared the audio file and the text generated by the speech recognition engine. Yeah. Yes.
Okay, thank you. And I think this next question can be answered by either of you. How prevalent is the following flow process in current practice? 1, non-interactive speech recognition dictation. 2, review of speech recognition generated document by a transcriptionist like professional. And then 3, review of corrected documentation by the clinician.
Well, I can speak for our experience, and I'm curious to hear Lee's answer too. In my experience, in the clinic, the most common is interactive use of voice recognition. In the hospital, it is most common that is done non-interactively, and every note that's dictated these days is almost every note is processed by an NLP engine, a speech recognition engine, and then the transcription and corrects it. So that would be number 2, and the third option, where it's non-interactive and the clinician corrects it. In my experience, that is very new here, and I think it's an underutilized and potentially very useful mode for workflows such as inpatient progress notes.
I think the physician's preference of different mode of using speech recognition technology in their workflow is probably different based on their background, if they're a native speaker or worse now, like me, I'm not a native English speaker, or if they're, not familiar with this new technology. And also, I think the dictation, at institutional level is also related to the cost of, typing versus traditional transcription services versus the speech recognition software that clinicians can dictate directly. Those other factors need to be considered where the clinicians or the institutions choose which mode to use.
Thank you. And Lee, a question came in for you about whether you have any data on the extra time spent for correcting speech recognition only notes by physicians.
This is a good question too. We are so currently we are doing observations for the looking at the observe the clinicians dictating notes using speech recognition software in their practice, in their clinic's office. And so then we can look at the time, they dictate on and the time they spend on their correcting. So there's not much literature, study in the literature about the difference. I also, heard from some news or some physicians talking about that they actually, spend a large amount of time on editing the notes after dictating the notes. So also it varied from clinician to clinician as well. Yep. So the data will coming up where we are doing front-end speech recognition. Yeah.
I might just add that we have one of our computer science graduate students is working on assisting with the editing process, because much of this editing is pretty mechanical. Some of it requires clinical judgment, but some of it's mechanical. And he and his faculty advisor are working on methods to reduce the burden of editing for physicians.
Great. We have a question here about whether any of the dictated data was converted to discrete data within the EHR versus remaining as text in a dictated note.
Well, I can answer for us. Previously, we've worked on a method that is now commercially available to process a note and to identify candidates for probabilist entries. So that's up to the physician. That's outside of our study, but it's amazingly good. It includes negation, probability. It considers the section of the note in which a phrase appears, for example, family history versus in the patient his or herself. So that is an exciting frontier, and that's how far we have progressed. But to me, this work we're doing now is a prelude to greater use of NLP technologies for many really exciting purposes.
I can see the R01 grant submission now.
Yeah, you might just stamp it approved and save everybody a lot of time. Thank you.
We have a question here about the mTerms NLP tool. Is it open source for download?
We're working on that. It's not open source yet.
Okay. There's a question here about whether the system automatically excludes word whiskers like etc., because the questioner here noticed that these were not transcribed as spoken.
Yeah, our software, we use Dragon for this, and it does a remarkably good job of removing those sorts of phrases, and I think that's a real credit to the engineers who produced that.
Yeah, it's terrific.
Yeah.
Tom, this one's for you. Could you speak about the deployment model used for VGEENS? Was it internal to the hospital network, or was it developed for a mobile device? I think you may have said something about that before, but would you mind repeating it?
Yeah, if you can go back to slide, I believe it's slide 23. This is what is used at the bedside. This was an inexpensive cell phone with an app we developed on it. The app has the buttons you see there. That's all that's used at the bedside. So it's very simple. It was designed to be very simple. We don't expect anything more complex to fit into the busy world of hospital rounding. And we'll have a paper describing this by one of our residents wrote this app for us and put it together with the other components of the VGEENS system.
A follow-on question here about VGEENS. How exactly did VGEENS combine the voice recognition and transcription with the EMR? Are they integrated or side by side? And there's an assumption.
They're integrated.
Okay.
Yep, go ahead. I let you finish, Chris. I'm sorry.
No, that's quite all right. The questioner assumes that the physician is checking the final note before sending it out. And were there any studies comparing notes before and after checking?
So yes, the questioner is correct. This, the note that's produced by VGEENS is transmitted to the EHR inbox. And there it is edited by the physician before it is signed, just as it would be if it were a dictated note. So it is integrated with the commercial EHR. It also extracts data from that patient's record in response to voice commands. So if you say, please insert vital signs, it will extract the vital signs from that day, format them nicely, and put them into the note. So there's several levels of integration with a commercial EHR.
Great. Another question about VGEENS here. In addition to including ICD codes as structured data in the note, is it able to include any additional structured data like LOINC codes, AHRQ or SNOMED?
One minor correction to that question. We represent the problem list entries using SNOMED CT rather than ICD, since we feel that, in fact, we have evidence to support that SNOMED better represents the concepts used in problem lists than ICD, whether it's 8, 9, or 10, or 11. And yes, the same could be applied, and if we had more time, we would have done it, to LOINC or other nosologies, because I think that gives our computing systems the potential to help us with advice that might be very useful for patients once the content of the narrative text is, quote, understood, unquote, by the computing systems.
Right. And then as a final question here around VGEENS, what role do you foresee for VGEENS in other types of reports, such as discharge summaries, et cetera?
Well, we didn't intend for them to use it for those, but they did anyway. I think it's a great potential because those documents are common and sometimes time-consuming to create. So VGEENS is, I think, well-suited to those purposes. There are a few mechanical things we would have to change, but that could be done. And also admission notes are often brought, they include patient information from a history and physical, but also outside records. And using something like VGEENS with very rapid turnaround, 5 minutes, would help us summarize those voluminous records in a way that other people caring for the patient can then read and understand.
Great. Well, thank you both very much for answering these questions. We've reached the end of our time for this webinar. I'd like to thank everyone for attending. For those interested in obtaining continuing education credit for participating in this webinar, you can visit the URL shown on this slide. You will select today's webinar, which will be indicated by date and title, and then complete a very brief evaluation of the event to claim your credits. You will have 60 days to claim your credit for participating in this webinar. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete this survey to share your feedback with us. Again, thank you all very much for participating in this terrific webinar. We hope you'll join us for future learning opportunities. Take care, everyone.